Good morning. My name's Winnie Nolan. I'm a consultant ophthalmologist at Moorfields Eye Hospital, and I have a research interest in the epidemiology of glaucoma and prevention of blindness. Glaucoma is the commonest cause of irreversible blindness worldwide and the commonest cause of blindness after cataract. So the content of this talk is going to focus on the prevalence of primary glaucomas and risk factors for those glaucomas, and then touching on challenges that we face. So we'll start with definitions. The ISTIO classification of glaucoma was devised to really come up with a standardized definition of glaucoma so that prevalence studies, epidemiological studies, could then compare figures and prevalence figures. And prior to that, there was very variable definitions of glaucoma. So this was devised over 10 years ago by a group of experts in the field. And there are three categories of diagnosis of glaucoma that can be used. So I'll go through those. The first is category 1, and this is the main definition. And using this diagnostic criteria, this is based on structural damage in the optic nerve. And what you tend to do is take the distribution of the cut-to-disc ratio in the population you're looking at, and a cut-to-disc ratio falling beyond the 97.5th percentiles for that population, for the normal population, would be abnormal. So you're looking for structural damage associated with a visual field defect consistent with glaucoma. And the other definition of structural damage would be focal thinning of the neuroretinal rim in the superior or inferior rim. In cases where you may not be able to get visual field data, and that may be because the patient can't see well enough, or there may be other abnormalities preventing them from doing that, a more stringent definition of structural damage, so a cut-to-disc ratio or disc asymmetry falling above the 99.5th percentile for the normal population. And then in cases where you may not be able to see the optic disc, or it may not be visible. So patients who have significantly reduced visual acuity and another hallmark of glaucoma, so either markedly elevated intraocular pressure or evidence of previous glaucoma filtering surgery. Then for primary angle closure glaucoma, the same group came up with a definition for that, which was quite controversial at the time. And this definition follows what we think is the natural history of the disease. So progressive change from a anatomically narrow angle with apposition between the peripheral iris and the trabecular meshwork, but no other abnormalities. And then the next stage is primary angle closure, which also shows apposition, but with another abnormality consistent with angle closure, such as elevated intraocular pressure, peripheral anterior synechii, which you can see here, which are permanent adhesions between the iris and the angle wall, or signs or symptoms of a previous attack of acute angle closure. But the definition of primary angle closure includes no optic disc damage. And then finally, primary angle closure glaucoma, where again there is evidence of either permanent or reversible appositional angle closure together with glaucomatous optic neuropathy. So then there are a number of prevalence surveys, many of which now use the ISTIO classification. Some of the older studies use different definitions of glaucoma. And as you can see from this table here, the highest prevalence of open-angle glaucoma occurs in Africa, and you can see very high rates, particularly in West Africa, up to 6.8%, and unpublished data from the Nigerian survey showing similarly a high prevalence, and this applies across Africa to Eastern and Southern Africa as well. And then in European-derived populations, it's approximately 2%, and in Asia, similar. And this is generally in the population aged 40 and above. Primary angle closure glaucoma, a different distribution. It's relatively low in prevalence in European or European-derived populations, and a recent meta-analysis of these populations gave an overall prevalence of about 0.4% for that population. But it is commoner in Asia, and we'll come back to this and break it down a little bit. You can see it's roughly around 0.8 to 1% in the population aged 40 and above. And it does occur in African populations, which it was thought not to exist, but it does. This requires the definition or the finding of angle closure cases requires gonioscopy, and so that needs to be part of the prevalence survey, and that's how the definitions are based. So what are the risk factors for primary open-angle glaucoma? Well, the candidate risk factors, I will go through some of them in detail, and we'll focus on intraocular pressure. All glaucomas have an increasing prevalence with increasing age. Ethnicity, family history is an important risk factor, and one risk factor which we can consider using in case detection. First-degree relatives will have a higher prevalence or incidence of the disease. And the other one, which I'm not going to focus too much on, is refractive error. And increasingly, we're seeing that people who are highly myopic are more at risk of open-angle glaucoma, and hyperopic patients more at risk of angle closure. So this data is taken from many of the prevalence studies, and these are projections for how the prevalence of open-angle and angle closure glaucoma in different age groups. And you can see that for both types of glaucoma, the prevalence increases quite dramatically with age, and that increases more in the populations with a higher prevalence. So for open-angle glaucoma, the African population show quite a dramatic increase in the prevalence of disease with age, and in angle closure glaucoma in China, where this is more prevalent, this is increasing. So these are potential public health problems approaching or present at the moment, because we have an increasing aging population who are living longer in all parts of the world. Intraocular pressure is the strongest causal factor in glaucoma, and we now have good evidence from randomized controlled trials and studies to confirm this. And this is really where the focus of treatment is based, is on reducing intraocular pressure. This is data taken from the early manifest glaucoma treatment study, where patients were randomized either to be treated and have intraocular pressure lowering, or were managed conservatively with observation only. And what this is showing is that with an increase in intraocular pressure in patients who had lower intraocular pressure, there was progressive glaucomatous visual field loss, and you can see that the number of patients progressing is shown on this graph. But you can see in this graph on the right, where patients had a higher intraocular pressure at baseline, a significantly higher proportion of patients would develop progressive glaucoma, both in the control group and the treatment arm. And what they found is that when in the treatment arm, for each 1 millimeter of mercury reduction in intraocular pressure, you would achieve a 10% reduction in visual field progression. And so that really gave us the strong, robust evidence that lowering intraocular pressure significantly reduces the chance of progressive glaucomatous visual field loss. Then central corneal thickness is a bit controversial as a risk factor. A lot of the evidence which really supposedly supports this came from the ocular hypertension study, where they found that patients with a thinner central cornea were more likely to convert to glaucoma from ocular hypertension. However, that study was a sample that had selected patients with higher central corneal thickness who had ocular hypertension as part of their selection. So that's not really been factored into it. What we do know is that intraocular pressure reads lower in patients with thinner central corneal thickness. So whether we have adjusted significantly for that effect of central corneal thickness, and whether central corneal thickness itself is an independent risk factor for progressive glaucoma, developing glaucoma, still a bit unclear. And there is data to suggest that the population most at risk of primary open-angle glaucoma, i.e. African populations, have thin central corneas. So there may well still be evidence that it is a risk factor, but it's not entirely clear at the moment. Ethnicity. So again, we go back to the fact that certain glaucomas are prevalent in certain parts of the world and populations, and we know that angle closure has a higher prevalence in Asian eyes, and primary open-angle glaucoma has a higher prevalence in African patients. And this is a meta-analysis which looked at all the population-based surveys and came up with summary figures as estimates for the prevalence of primary open-angle glaucoma in these populations. You can see again this supports the fact that primary open-angle glaucoma is commoner in African or Black ethnicity patients. Pseudoexfoliation is a condition that's associated with cataract, and it's associated with glaucoma, and it's associated with blindness due to both those conditions. And it's prevalent in certain parts of the world. Traditionally, it was thought just to affect Northern European, Scandinavian-derived individuals, but we know now from a lot of data that it occurs in pockets around the world. So it's strongly prevalent in Northern Europe. It is prevalent in parts of Asia, including India and Northern Asia. And whereas you don't see it in West African eyes, you do see it in Black South Africans. And a gene has been identified which codes for elastic fiber synthesis. And this is a strong risk factor for the presence of pseudoexfoliation. However, not all individuals with this gene develop pseudoexfoliation, so we think there may be environmental or other factors which trigger the development of pseudoexfoliation. But as a cause of blindness, it's a significant one. Systemic factors, again, evidence is conflicting on whether conditions like diabetes and hypertension put individuals more at risk of glaucoma. We do know that nocturnal hypotension is a risk factor for visual field progression and optic disc changes in glaucoma, and this is with particular reference to patients with normal tension glaucoma. And patients who have systemic hypertension may get reduced perfusion of the optic nerve due to nocturnal hypotension and the effect of their antihypertensive medications. The pathophysiology of this is not entirely clear, but it probably revolves around perfusion of the optic nerve head and the autonomic regulation of that perfusion and flow through the optic nerve head. And vasospasm, which you may be associated with patients with normal tension glaucoma, can also cause progressive visual field loss. And typically you may see this in individuals who get other features of vasospasm, such as Raynaud's phenomenon and migraines. That's a small subgroup of the population. With regards to diabetes, the big prevalence surveys showed conflicting evidence as to whether it's associated with elevated intraocular pressure or glaucoma, so inconclusive really at the moment. So on to primary angle closure glaucoma. You can see from this table here that 85% of all angle closure glaucoma is present in Asia, so that accounts for it. So again, it's potentially a big public health problem in Asia. And if you match this with the increasing burden of an elderly population, particularly in China and countries such as Indonesia, you can see how this is going to be significant now and in the near future. And this map just shows you a breakdown of the prevalence from surveys which use the ESGA definitions in the last 10 to 15 years. And it's a similar prevalence. I would say the prevalence is higher in this population because they were looking at an older population, and we suspect that the Burma survey shows a higher prevalence due to the presence of unoperated cataract, so that in itself is a risk factor for primary angle closure glaucoma. As a cause of blindness in Asia, primary angle closure glaucoma is a more visually destructive and blinding disease, and this is data from prevalence surveys conducted across the region, which shows that patients with primary angle closure glaucoma, almost approximately half of them are likely to have one eye blind. which is almost twice as much as for primary open-angle glaucoma in that particular population. And typically, anecdotally, when you see primary angle closure glaucoma in Caucasians, you don't see it as such a blinding disease. So it suggests there's a different clinical phenotype to the glaucoma in Asian eyes. Risk factors. A lot of this comes down to biometry and the relationship between the lens and the rest of the eye. As people get older, the lens increases in size, and so the prevalence of angle closure goes up. Women and Southeast Asian populations are more likely to have angle closure, and this is probably due to them having smaller eyes. So a big lens in a small eye is going to predispose to this, and I'll come back to social deprivation later. And this is just focusing in on those biometric risk factors. So the presence of a big lens, possibly anteriorly positioned in a small eye, and crowding of the anterior chamber. These are long-standing measured risk factors which were identified in the Greenland Eskimo population 20 to 30 years ago as risk factors for angle closure. And now with the advent of anterior segment imaging, we can be more specific about exactly what's going on. And it's not just necessarily about the lens, but it might be about the dimensions of the anterior chamber. So a small width anterior chamber with a thick iris. Typically, these are features of Asian eyes with angle closure compared to Caucasians. And the most significant factor that's been measured is the lens vault. And that is the distance between a line transecting scleral spur to scleral spur and the anterior surface of the lens. And the higher or the larger that measurement is, the much higher risk patients are at developing angle closure and raised pressure. A surrogate measure of that is the anterior chamber depth, which is the distance between the cornea and the anterior lens surface. And you can see from this graph, which measures the anterior chamber depth in various different populations, that populations with a deeper anterior chamber, for example, the European-derived populations, firstly, they have a much lower risk of angle closure. Inversely, those populations with the shallowest anterior chamber, such as the Greenland Inuit, have the highest prevalence of glaucoma. And what you can see most markedly is that with age, the anterior chamber shallows, and that's why the prevalence of the condition increases. Glaucoma is different from cataract. Patients are not aware that they have the disease. And even in populations, high-income countries, European countries, where case detection programs may exist in optometry, we're still only picking up 50% of glaucoma. Then take that to countries like Africa, India, and you can see that up to 98% of glaucoma is undetected. So patients can present very late. And late presentation is a risk factor for glaucoma blindness. And we know from studies conducted in the UK that these are case control studies, that late presentation is associated with social deprivation. And a study was conducted in Birmingham looking at presentation of acute angle closure in the West Midlands, and found that a disproportionate number of patients and cases were coming from the most deprived population. And this, again, may be something to do with unoperated cataract, or it may be a relationship between social deprivation and the biometry or other physiological factors in the eye. So having established that this is an important cause of blindness and a public health problem in certain parts of the world, what are the challenges to reducing the rates of blindness due to glaucoma? Before we can start trying to detect cases of it, we have to have an effective treatment. And we need to develop an evidence base with randomized controlled trials of different treatments. And we're not really there yet at the moment, though there is good work going on. In primary angle closure glaucoma, this may be simpler because there are trials which are comparing lens extraction and laser iridotomy, and there are trials looking at screening for angle closure and early iridotomy. So we await the results of those trials. Primary open angle glaucoma is more challenging. medical treatment is the mainstay of treatment, but is not necessarily a sustainable method of treatment, particularly in low-income countries. And surgery is not always that acceptable to the patients due to poor outcomes. Once we have a treatment that works, detecting cases is important, as you can see from those high prevalence rates of undetected glaucoma. And this will come down to methods of case detection, using risk factors, and improving public knowledge and access to treatment, which is very poor for glaucoma. People have a lot of fear about treatment such as surgery due to current poor outcomes. So these are the areas that will need to be focused on to implement prevention of blindness programs for glaucoma. Thank you.